many thanks for joining us. This is the VASM Webinar, which is really about non-operative skills, but we've entitled it Patients with Patients tonight. So basically, I'm Philip McCahy. I'm the Clinical Director of VASM. We've got a very high-powered group giving us talks today. We've got the Chair and the Vice Chair of the Victorian Perioperative Consultative Society, Council rather, and we've also got the author of really probably the main papers on this subject over the last few years. So hopefully you enjoy it. RACS would like to acknowledge the Aboriginal and Torres Strait Islander people as the traditional owners of the lands that we are all on today, and extend our respect to elders past, present and emerging. We respect their continuing connection to culture, land, waterways, community and family. Right, my first slide. What I thought I'd do is to try and give you an idea of what we're going to be talking about tonight with a couple of cases. And this might be quite familiar to a few of you because it is the current ANZASM case of the month, which was sent out to all those that subscribe to the ANZASM on the emails. And as you can see, it's a 70-year-old guy with a one-day history of right iliac fossa pain and sepsis, with lots and lots of comorbidities, and both clinically on CT, he had appendicitis. So a lap appendicectomy was performed, which was a little bit tricky, and a tubular friable structure was removed. Over the next 3 days, the patient became quite a bit worse, multiple MET calls, still running a temperature, and a repeat CT at day 4 suggested that the entire appendix was still present. Around about the same sort of time, the histology on what was taken out came back as fibroadipose tissue. Went back to theatre, had an extremely difficult perforated retrocecal appendicectomy and deteriorated over quite a few weeks, eventually dying in ICU on day 40. The assessor identified a whole load of issues. As you can see, I've broken them up, and this will probably tie in with one of the presentations later on into technical and then different types of non-technical skills. The first problem being a technical one, and that the appendicectomy didn't find the appendix. Second one's about decision making. They didn't realize that the abdominal pathology was still present, either at the time or later. There was a communication issue, and the nursing staff were unable to contact the surgical team numerous times. And the documentation, according to our assessor, was not very good. Overall, it was unclear who was in charge of the whole thing, which is a matter of leadership. And again, about leadership as well as situational awareness, the senior surgeons did not get involved until really quite late in the situation. So all sorts of issues went on with this patient. Very few of them were technical. You'd imagine the surgeon doing the operation actually was quite good, but the patient died from appendicitis, remember, due to all sorts of non-technical areas. Another case, this is a VASM case, an 80-year-old male presented with massive melena and unconsciousness. It collapsed a couple of times in a day and ended up having probably an external CT, so GP might have arranged that, suggesting a cecal bleed. Went to the hospital and they got focused on the cecal bleed and decided that he probably needed to go off to a tertiary centre rather than be dealt with locally. So it was transferred, but during transfer, as you can see, had a lot of blood and tranexamic acid, and arrived late in the morning very early in the morning at the tertiary hospital, very, very unstable, but still took about 4 hours with further blood going in before getting to theatre, where he was found to have an actively bleeding DU, poor views, went to a laparotomy, ulcer underrun, more blood loss, more problems, and eventually got into very much a terrible terminal cycle and died with renal failure and further melena a few days later, and a one-way extubation. You can break this down to probably mostly non-technical skills, situational awareness. The first hospital got fixed on the wrong diagnosis and felt we can't deal with this, we have to send him off, where they probably could have dealt with an upper GI bleed that had crossed their minds. Communication within the first hospital and between the transfer, and this is one of the things that we brought up in our report last year, and that really if transfers should involve that senior people communicating directly to one another. That didn't happen here. And so no senior people were involved in the transfer discussions. The patient ended up with the second hospital and the surgical team not really being aware that this guy had arrived. And then when they did get to the second hospital, the gastroenterologist, for some reason, decided to delay doing the endoscopy, and the patient deteriorated even further. So hopefully that's given you an idea of the sort of things we're going to be talking about tonight. Our first speaker is Pipiris, who is an orthopaedic surgeon, probably well known to a lot of you, but more importantly is the chair of the VPCC. So over to you.
Firstly, I'd like everyone to sort of think about the patient, and we'll make the patient the centre and the relatives the centre of the discussion in this particular part of the webinar. And the patients, I'd like everyone to remember that they rarely remember the sophistication that goes into the technical aspects, our diagnosis, and the brilliance of our operation. But what they do remember is, you know, whether we listened and whether we cared, and whether we had the patients to really understand what they were trying to communicate. And patience is probably one of the more underestimated non-operative skills, and perhaps the hardest one to pull out, because everyone sort of feels the time pressure of the consultation, the numerous competing demands, the information that's being collected, the infrastructure demands placed on their time, and patience often goes out of the windows. And when you look back at a lot of the work we do, and I work with Phil on the PMC, which is the Mortality Council, and we look at all the complications that come through VPCC, and if you drill down and take out the technical aspects of the conversation, you probably find that patience or communication is probably at the heart of about 70 to 80% of a lot of the adverse events. And whether that's between the doctor and the patient, whether it's between the patient and the doctor or the surrounding team, and Ben will talk to you more about the team, all these things contribute to maybe some poor decision making on our part. And the better communicators we are and the better situational awareness we have, will make better decisions for the patient. And that's why it's important to peg it all back when you're feeling time poor and pressured, to try and put the patient at the centre of that particular consultation. Because when you take clinicians back, and we do this at the hospitals all the time, and we debrief with each other, they often don't say, they sometimes do say, you know, I should have done a different operation, but often, you know, it's like the patient was telling us something, and in retrospect, the warning signs were present. And a lot of the time, this reflects the point that we just closed ourselves off to many of the bits of information that were coming in that tried to help us in our decision making. So, and here's a good example that people should be mindful of. And any time you think when there's a problem that it's just a normal post-operative course, just think of patients like this that you all know. And this is a patient that came across the VPCC and the PMC. It's a 68-year-old who presented 7 days after colorectal surgery with increasing abdominal pain. The family said they looked different. The patient didn't think they felt right. There was an elevated CRP and ESR. They came to emergency. They talked to the registrar. They went home. And then they came back 24 hours later and they were quite septic. And, you know, we sit there and go, well, that was a point where we probably missed the diagnosis and we failed to rescue. But in actual fact, what the lessons from it is we probably failed to stop and listen to the information that was coming from the patient. And we anchored ourselves to a particular diagnosis. And it was very hard to shake us from that particular diagnosis. And we probably prematurely closed the conversation on that because we put up the blinkers, and then it was a bit of a challenge. So when we're sitting there and talking about patients, when there's communication with patients, you know, we sit there and go, well, you know, we shouldn't be interrupting people, and we shouldn't be thinking of everything except for the patient, and we're missing information. whereas we should be sitting there and listening to every word that the patient has to say and everything the families have to contribute. So therefore, we can sit there and try and take all the information in, appreciate the risks that are appearing, and think about how we may prevent these things. So the greatest diagnostic tool, I suppose, is not really all the tests we think about, and they're very important, don't get me wrong, but it's also the family and the patient and what they have to say in terms of how well they feel, and it's important we listen to them. So this is another issue that often comes along, and this is a patient that came along, and it was a patient that was a 78-year-old who had some orthopaedic surgery and presented 2 weeks later with some pain and swelling. Presented on a number of occasions, was each time was thought to be okay. Did have an ultrasound at one time along there that was negative, and then presents 14 days after the operation with chest pain, with a massive pulmonary embolus that led to some pulseless electrical activity, and the patient dies with a pulmonary embolus. So we can say that we played pretty hard to try and diagnose this with one ultrasound during the whole time. But, you know, I think when we reflect on it, we can sort of think that we probably had a cognitive bias. We anchored ourselves to the fact that we'd done one ultrasound and it was negative. We sit there and try and figure out risk, but just because the patient's coming on a repeated occasion, it doesn't mean that there is a decreased risk of that particular complication. We should approach each new consultation with the respect that it needs, and it's important to realise that there can be a failure to appreciate a change in the clinical circumstances. So we need to make sure that we remain active and we invite concerns to come along, and we sort of create spaces where patients can communicate all the various concerns that they have. But we also sit there and we remain curious. So every time there is a problem, we remain curious about why it's there and what we need to do about it. Next. So, you know, the patients and the family often recognise deteriorations before the monitors. So I think the thing is we need to be patient enough to listen to them and brave enough to really question our cognitive biases. So this is another patient. This is a patient, there was an 88-year-old who underwent some coronary artery bypass grafting and was confused in the post-operative period. And the wife was concerned along the way that this wasn't normal for them, that he was pale and restless and withdrawn. And this was through the evening of it. Nothing much turned up. You know, the pressures, they were a little low, but very much in keeping with the post-operative course. But overnight became increasingly hypotensive, suffered an arrest on the cardiac ward, had an emergency stenotomy, and died despite resuscitations. So it's important that we listen to families as baseline observers, and we try and incorporate all this collateral information into our decision making, and it's something I think we can do better. So it's important that patients, you know, with patients, the patients feel heard. It demonstrates respect. It builds trust, and it often, if it's open and honest, it'll probably lead to a safer outcome. Particularly the question as to why, and the question we need to ask ourselves is why we are not listening to the information that's coming in, and challenge ourselves to be more open to this information. So the failure to rescue, I think, becomes often begins with a failure to listen with patients. So what we need to do is really, what does patients look like for the clinician that's very busy? It's like listening again, remaining curious, re-examining assumptions, and realising that the patients are trying to tell us something that's really important. And you know, we need to put aside all these issues of time pressure and overconfidence that we have, and our perceptions of families and their contribution, and the hierarchies we grow up in. And we need to move to of appreciating these types of patients. And every time you sit there and get a little grumpy, and I sit there and think to myself, well, why am I annoyed? Why am I stressed? Why am I not listening? And why am I having to explain things on a number of occasions? It's because it's required. And that's what doctors need to do in order to be great doctors. So Explanation patients, we all need a little bit more of that. Emotional patients, waiting patients, particularly when information's coming slowly, behavioural patients, repetition patients. There are all these types of patients that we need to include in our armamentarium and go through them each time we're challenged and we're feeling a little anxious about our time and us and what we need to do instead of what the patient's going through. So really, instead of assumption, use curiosity. Instead of being dismissive, use listening. Instead of having delays, use early recognition and really focus on eliminating harm and promoting safety and a good safety culture. So hopefully that's a nice little introduction to the symposium today, and we look forward to taking some questions down the track. Thank you very much, Phil.
Thanks very much, Marini. That was brilliant. We shall move on now with our next presentation, which is from Ben Slater. Now, Ben is an anaesthetist, so he works very closely with us. He is the deputy chair of the VPCC, so we're very honoured to have him here as well. But I think problems with these sorts of things don't just occur to surgeons. They occur to all doctors, to nurses. And I think it's good to have a different perspective. And Ben will certainly be able to give us that. He sits on the VPCC. He's been in charge of the anaesthetic part of the Consultative Council for some time, and also regularly came to the Perioperative Mortality Committee that we run. So he's well aware of all these problems and can give us a somewhat different perspective. Over to you, Ben.
Hello, everyone. Thank you very much for the opportunity to present this evening. I have no disclosures to make, other than that this presentation is based in my own experience in case review at the VPCC, the Anaesthetic Subcommittee, and the PMC, as Phil said. So this is the outline of perioperative care that ANZCA put together, that they've called the nephron for obvious reasons. And I've just picked a few periods during this perioperative time when I think it's critical for surgeons to engage and to lead the perioperative team. So those times are the decision to operate or not, priming the team before a list, the intraoperative crisis, and then post-operative critical care. And looking at these times, I'm going to look at the multidisciplinary meeting first. Then we'll look at the concept of the huddle. Then we'll look at crisis and communication in a crisis. And finally, we'll talk a little bit about ICU and the issues of the closed ICU. So the multidisciplinary meeting. Don't need to have a multidisciplinary meeting for a 40-year-old marathon runner who needs their lap collie, obviously. But if you have a patient who is having surgery that's one part of a complex scheme of therapy, such as in oncology, or if you have a patient who's physiologically unstable, or where the disease process is complex, or if the surgery that you're performing is unique or rarely performed in your institution, then a multidisciplinary meeting can be really useful. And I'm probably preaching to the converted when I say that it would involve a holistic presentation regarding the patient, and that would include their values, goals, and preferences. The ability to listen to the concerns of other craft groups, and then a decision about whether to operate, modify the operative plan, delay the surgery, or not to operate at all and to offer alternative therapy. And one of the things when you read about our multidisciplinary meetings is constantly highlighted, and I think is really important, is their amazing educational opportunities for all members of the perioperative team and for medical and other students that might be going through the process. One of the issues with the multidisciplinary meeting is that maybe you can move your team from this concept of multidisciplinary care, where everyone's bringing their own viewpoints to what's going on with the patient. With over time, you work together so much that you move to this concept of interdisciplinary care, where you all understand where the patient, where the patient's treatment options, and you all work together on the same page and move in the same direction. So I've taken the ANZCA perioperative care team diagram and just adjusted it a little bit to represent how I think the multidisciplinary meeting should work. So I've put family and carers centrally with the person or the patient that's involved, and they're right in the middle of what's going on. And then I've added ICU and anaesthesia as specific teams that should be involved. And just instead of having nursing teams as a separate, I've just assumed that they fall within the teams, the specific named teams that are there. And then I've taken the surgeon out as a sort of an equal and placed them over and above as the leaders of the process. And why would an anaesthetist do that? That seems rather unusual. But the surgeon knows the patient best. The surgeon knows the procedure best. And the surgeon, in my opinion, should be driving the discussion and driving the decision-making process, listening to the other groups and taking on what they have on board, but in the end being the real expert in the room. So moving on from the multidisciplinary meeting to the preoperative huddle, the preoperative huddle is really a key sort of part of the process of priming the team at the start of the day. Now, I've never worked in a hospital really where this is practiced regularly and really well, but I really wish I did. And the meeting of the intraoperative team before the start of a list, discusses what each person is worried about on the list on the day, because what I'm worried about as an anaesthetist might be a difficult airway in a patient that's having simple surgery, but there might be a straightforward anaesthetic in a patient that's having complex surgery. And the theatre tech in the room may be worried about the new tower which has come in, which she doesn't really understand how it works properly. So there might be a patient that needs specific antibiotic therapy. There might be a whole heap of things that you go on that you could just simplify the day by just discussing them at the start and getting everyone on the same page and getting everyone primed for a good morning or a good afternoon or a good day. Now, the benefits of the huddle are that they lead to improved flow of the lists, improved team performance with that shared mental model. And it's speculated that there are improvements for patient safety, but with single centre observational studies really only to go on, that's not the case. The huddle is recommended by the Australian Centre for Quality and Safety in Healthcare as something that should occur. And on the left-hand side is an example of a checklist that I found that you could use for each patient at the start of the list to run your huddle. All right. Well, once the operation starts going, one of the things that can occur, of course, is an absolute crisis. And I do a lot of cardiothoracic surgery, and just every now and again, one of the problems that we run into is like severe bleeding. So I'm just going to use that as an example. And I want to kind of highlight the difference between two types of surgeons. The first surgeon is the kind of surgeon who you have severe bleeding and they let you know what's going on and they talk to you about what's happening and they allow you to be a part of the team and to work with them to solve the problem. But there's a second type of surgeon, and that's the type of surgeon whom in a high cognitive load situation, the communication dries up, they shut up, they stare into the small hole they're operating in, which no one else can see into, and it's impossible to tell what's going on except for the fact that the sucker is slowly increasing in volume. Now, in an ideal world, you'd solve this problem by doing team-based simulation beforehand and therefore giving the surgeon cognitive schema to work with, which decrease their cognitive load and allow them to communicate and do all the things better because they've practiced it. But that's not necessarily straightforward to set up. So what needs to happen, hopefully, is that surgeons get to the point where they recognize when they're getting into this isolated kind of situation where they have sort of very high cognitive load. They start to communicate. They break the task that confronts them down into chunks. They offload the tasks they can, and they trust the team to do the things that they can't do. For example, if there's tremendous bleeding, it's probably enough for any surgeon to worry about how they're going to physically kind of stop the bleeding and stop the holes. You don't need to tell me as an anaesthetist how to fix the coagulopathy. I'm pretty capable of doing that. Do the things that you can do and trust the team that's around you to do the things that they need to do and decrease the cognitive load that way. So what about post-operatively? And this is a problem that we've talked about a number of times at the VPCC, and that's that once you take a patient to the intensive care unit, you lose a degree of control for the care of that patient. And that's because all Australian ICUs, or especially all Australian ICUs that are accredited for training, must run a closed model. Okay, so in a closed model, what we're describing is that the intensivist takes clinical responsibility for the patient management, and the admitting team for the patient just takes on a consultative role. And this is opposite to an open ICU, where the admitting team manages the patient in an ICU environment, and the intensivists consult when necessary. So there's no RCT level evidence about open versus closed ICU, but there are lots of systematic reviews and meta-analyses of observational data which strongly back the closed ICU model as providing better patient outcomes. And this is probably because you have strong clinical governance and standardized approaches to care. So those are the positives. And the negative, of course, is it can lead to conflict between intensivists and the admitting teams. And of course, there's multiple sources of conflict in the ICU, as illustrated in this diagram I've taken from the article mentioned on the screen. And the reason there's conflict in ICU is it's a high stakes situation. And often the decisions that have been made are shades of grey, they're ethically complicated. And also, you know, like there's ego involved. But you can break down the basic decision, the basic kind of places where these conflicts occur to whether to admit or not admit the patient, whether to manage, how you manage the patient, particularly when it comes to transitioning to end-of-life care, and then discharging or not discharging the patient at the end of the day. And to use examples, there are clearly times when the ICU, or when, in my experience, when the ICU makes decisions that are not correct. Okay, they might try and pass a rectal tube or a nasogastric tube across a complex and unstable anastomosis, or they might run an inotrope in a patient with left ventricular outflow tract obstruction. But then again, there are clearly times when the surgical and anesthesia teams, who have invested often huge amounts of time and energy in the patient in the operating theatre, have unrealistic expectations about the outcomes. And it takes a fresh set of eyes in the intensive care unit to really kind of work out what's going on with the patient and bring some reality to the situation. And of course, the answer to all these things is communication. And I think this parable sums up many of the issues with perioperative disagreements, if you were. And it's the Indian parable of the 5 blind men and the elephant. And each of them goes and feels a different part of the elephant and says, an elephant feels like this. So the person feeling the ear thinks it's soft, and the person feeling the tusk thinks it feels hard. And the person feeling the leg says it feels like a tree. And they all describe the elephant, but they all describe it in different ways. And then when they don't agree with each other, they argue. And when they argue, they don't trust each other. But they've all got a different perspective of the same situation. And I think it's really key and critical for all members of the perioperative team, whether they be ICU physicians, surgeons, anaesthetists, whomever, to realise that the perspective that they have on the patient is likely to be different to the perspective that other members of the team have. So just in summing up, I'd like to suggest that at almost all stages of the operative course, whether that's deciding whether to operate or not, before the surgery, during crises, or afterwards. A key aspect of surgical leadership should be to promote a shared mental model, so everyone's on the same page and everyone can adapt to challenges in the same way. And of course, this shared mental model should be driven by the North Star of the patient's values, goals, and preferences that have been discussed throughout the surgical process. If you get to the point where you need to challenge another member of their operative team because you don't think what the perioperative team, because you don't believe what they're saying is right. I just put this up there as a useful strategy, and it's the I saw, I thought, I wondered strategy. And it's a sort of a non-confrontational way to point out that you think that something might not be right. So I saw that the patient had abdominal pain and a temperature, and I thought maybe they could have an anastomotic breakdown, and I wondered whether we should get a CT on this patient pretty early. And the bottom point here is just this point of unconditional positive regard. And unconditional positive regard is just assuming that every member of the perioperative team is doing their best for the patient and doing and trying their hardest and their best to achieve a good outcome. And if you go into every decision-making process that you have, or every sort of confrontation or every discussion with that as a background thought that the other person's just trying their hardest to do the best for the patient too, it's a pretty good way of keeping things collegiate and effective. So thank you very much.
Our final formal presentation tonight is from Darren Ey, who is a clinician in Adelaide, and he's done an awful lot of work with Guy Madden and various others in the ANZASMs about non-technical errors in surgery. So we are very, very grateful for Jesse to come along tonight and give us a summary of all the work he has been doing. So over to you.
Thank you very much. It's a lovely introduction, and I appreciate it. I'm genuinely privileged to be here this evening and very happy to share with you all something that I think is incredibly important and has taken up a good portion of the last few years of my life. So in surgery, non-technical skills refers to the interpersonal and cognitive components of surgical professionalism. This includes communication and teamwork, situational awareness, decision-making, and leadership. Now, if we contrast that to the technical components or the body kinesthetic components, we're talking about dexterity, instrument manipulation, tissue handling. There is quite a difference. Studies have actually demonstrated that most adverse events in surgery are not caused by errors in technical skill, as the previous presenters have discussed. They're caused by these deficiencies in non-technical skills. And there are a few seminal studies that really brought this to our attention. The first, by Gawande et al., who is the developer of the WHO safety checklist, looked at 444 closed medical malpractice suits and found that 66% of them had errors in clinical judgment. Another study interviewed 36 surgeons who recalled 146 specific incidents, of which a quarter had communication breakdowns linked to harm. Though these studies were very similar and sort of opened the floodgates for non-technical skill research, they're actually almost the only studies that have been conducted on this for trying to quantify the incidents. And to be honest, until recently, there's been very few large representative studies on non-technical errors in surgery. And the main reason for this is because non-technical skill assessment methods are significantly limited. First, they're all observational in nature. So that means in order to assess someone's non-technical skills or a team's non-technical skills, you need to have the expert assessor in the same time and place as the people being assessed. And as you can imagine, this is both prohibitive logistically and financially. But even more important, when you analyze someone, through this observational assessment methodology, you're only getting a cross-sectional single point in time assessment. So you observe someone's decision-making But the outcomes of that decision making may not become manifest for minutes, hours, or even days. And that's what we often see in surgery. The complications don't actually arise for quite some time after the process has happened. And so prior to this work, all non-technical skill assessment tools were completely disconnected from actual patient outcomes. And therefore, the incidence of non-technical errors leading to patient harm was really poorly understood. We sought to address this by developing the System for Identification and Categorization of Non-Technical Errors in Surgical Settings, or the SICNES, which was subsequently published in the BJS. We did a systematic literature review and modified Delphi process to identify the 4 primary non-technical skill domains. We then piloted this tool using 12 months of national mortality data, and we had moderate to strong inter-rater reliability for identifying non-technical errors linked to harm. We then refined the tool in 2 ways. The first way was to actually sort of work akin to a root cause analysis process where we would find the point of harm, we'd work backwards, and we would find the earliest non-technical skill behaviour that was deviating away from standard care. We then conducted a thematic analysis, and that gave us 50 unique real-world examples of non-technical skill behaviour deficiencies. Using this, we then conducted another 12-month pilot and improved the inter-rater reliability across all domains. So armed with this, we thought we could answer the question, what is the incidence and characteristics of non-technical errors associated with patient death in Australia? So we conducted an 8-year retrospective cohort study. We included all surgical mortalities that have been flagged as an adverse event or an area of concern across the entire country, reported to ANZASM. Each case was independently assessed using the SICNES by 2 reviewers, with disagreements resolved by a third. And what reviewers were looking for is if each case had a non-technical skill error linked to death, and if it did, to which of the 4 non-technical skill domains did it belong. Over the 8 years, there was 30,971 mortality cases in Australia. Of these, 3,829 have been flagged as having an adverse event or an area of concern. 134 needed to be excluded as they had insufficient data to use the SICNES, excuse me, leaving 3,695 for inclusion. And we identified that there was a non-technical error linked to death in 64% of this 3,695. And I just want to pause there for a moment, because if 64% of cases had a technical error or a serious infection, there'd be riots in the street. Of the errors we found, 58% of them related to decision making, 56% related to situational awareness, 15% to communication teamwork, and 5% to leadership. Here we have what's called a statistical process control chart, and this measures variability within any system. In short, this is showing us the trend in non-technical errors related to death over the 8-year period. And in the different colours, we have what's called special cause variation. So this is when the variation is no longer random and indicates a meaningful change. In this first graph, we've got the incidence of non-technical errors over the full 8-year period, inclusive of all surgical specialties. We can see initially there was a period of worsening in orange, and then there's a period of improvement right at the end in blue. And overall, this did meet the criteria for special cause improvement, meaning there was a meaningful reduction in non-technical error harm over time. It's a little bit small though, but I want to draw your attention to the final 2 years or 8 quarters. You can still see, despite it being meaningfully improved, it's still sitting around about 60% of all cases with fatal non-technical errors. When we looked at the different types of areas, we could see communication teamwork, there were changes, but there was no meaningful change over the full time. Same was true for leadership errors. For decision-making errors, the most prevalent error type, there was a period of worsening, but no improvement at all. And for situational awareness errors, there was no change at all. Now, to paraphrase George Orwell's Animal Farm from 1945, all surgeons are created equal, but some are more equal than others. And really, it's a bit tongue-in-cheek, but what we're saying here is we know decision-making errors are very common, and we know we need to do something about them, but changing the decision-making processes of an entire nation seems like a pretty tall order. And the truth is that within different specialties, there are bound to be non-technical skill priorities, different systems, different patient demographics, and just unknown variables that may or may not be influencing non-technical skill errors. So we thought to explore that. Over the same study period, what we found is about 95% of all mortalities in Australia flagged with an adverse event or an area of concern belong to 5 surgical specialties listed here. We found there was a statistically significant difference in the incidence of fatal non-technical errors overall across the specialties, but you can still see that they are significantly, well, they're still quite high. There was a statistically significant difference in decision-making errors, again, still very high across all specialties. Statistically significant difference for situational awareness, And there was no statistically significant difference between communication and leadership errors. As I said before, despite finding specific differences in specialties, the overall incidence was still unanimously high, and decision-making and situational awareness errors were still the most prevalent across the specialties. We did find in general surgery that there was a meaningful change over time, but similar to the last graph, the last 4 to 8 quarters are still sitting around 60%. For vascular surgery, there was no meaningful change over time. Orthopaedic surgery, no meaningful change. Neurosurgery, none, and cardiothoracics, none either. So the summary of these early studies, there is a high incidence of non-technical errors linked to patient harm or death for that matter across the specialties. Decision-making and situational awareness are the most prevalent despite the surgical specialty, and we've seen little to no meaningful improvement over time. We must do something about it. We've now been able to quantify the burden of harm, but we still really didn't understand when, where, why, and under which circumstances these errors were occurring. So this brought us to our most recent study, Non-Technical Errors, the Hidden Contributor in Emergency General Surgery, which has just been accepted in the Annals of Surgery. We wanted to look at emergency general surgery for a few reasons. The first is that it was the most populous group represented in the Australian mortality data, making up the most number of cases. Secondly, it represents a group that are high acuity, but also rapidly transition through phases of care, from initial assessment in DD to the preoperative phase, the intraoperative phase, and then post-operative care, either in ICU or high dependency. These we thought would be an excellent demographic to really dig deep and try to figure out when, where, and how these errors were happening. Specifically, we sought to find out the incidence and type of fatal non-technical errors, the specific behaviours driving them, the clinical settings in which they are occurring, and the team or teams involved in error occurrence. So over the study period, there was 11,565 emergency general surgeries, of which 1,164 had been flagged with an adverse event or an area of concern. We found there was a non-technical error linked to patient death in 67% of them. Similar to the previous studies, we found situational awareness and decision-making the most prevalent by far, with communication and leadership to a lesser degree. When we got granular though, in situational awareness errors, we actually found that 60.4% of these errors belong to only four key behavioural types: failure to recognise clinical signs and symptoms, failure to appreciate the severity of the illness, misdiagnosis despite clinical evidence, and failure to appreciate the need to consult another team. The same was true for decision-making errors, 67% of them attributable to only 4 behaviours: failure to initiate the intervention appropriate for the clinical context, incorrect operation performed, or management being either too aggressive or too conservative. We didn't find any trends in the other 2 domains, but it's likely because there was a significantly or substantially smaller proportion of errors belonging to this. Really interestingly, we could identify the phase of error occurrence in 97% of errors. Preoperative was the most prevalent at 57%, followed by postoperative and non-operative, with intraoperative making up the smallest amount of errors. In fact, approximately 90% of surgical non-technical errors linked to surgical patient death occurred outside of the operating theatre. When we assessed team responsibility, we could determine it in 95% of cases, and 84% of the errors arose in a single team, with 11% contributed equally by multiple teams. When we looked at the single team errors, the surgical team was responsible in 73%, but more than a quarter of the surgical non-technical errors, or non-technical errors in surgical patients more appropriately, occurred completely independently of the surgical team. And these were most commonly occurring in the emergency setting, ICU, or an undefined medical team. For the multiple team errors, the surgical team was involved in 94% and the non-surgical team in 96.6%. And again, there's a list of the most prevalent contributors thereafter. So what does all this mean? Well, first, we've been able to quantify that non-technical errors do in fact contribute substantially to patient harm here in Australia. This is consistent across surgical specialties, and even though there are specialty-specific differences, it indicates that there's still a systemic problem that needs to be addressed. Concerningly, we found no significant improvement over time, which means, despite best efforts, historic non-technical skill improvement efforts have been insufficient. The fact that 90% of fatal non-technical errors occur outside the operating theatre is a finding that we didn't expect, and in fact fundamentally challenges non-technical skill assessment and improvement research, which has primarily been focused intraoperatively. We found that errors predominantly arise within surgical teams, but with more than a quarter of them arising in non-surgical teams. For the first time, we've been able to quantify the importance of a broader approach to non-technical skill improvement. As Dr. Slater said before, this is not just the surgeons working in isolation, it is the entire care team. Importantly, we found that most of the errors that are occurring can be mapped to only a few specific behaviours, and this provides clear targets for future improvement interventions. And I'm quite optimistic about moving forwards. But what do we do from here? It sounds a little bit doom and gloom, but I think it's an incredibly exciting space. We've got a great opportunity to make change here. First, we need to continue researching this. We've only touched the iceberg. We've looked at mortality only, which I'm sure you all agree is the minority of surgical patient care. Some pilot work we're doing here in Adelaide informs the hypothesis that we think the incidence of non-technical errors in morbidity may be as much as tenfold that of mortality, but we certainly need to look into that further. The second is, what do we do about it? Currently in Australia, and in fact across the world, non-technical skill assessment does not occur as a routine part of clinical practice. However, there are widespread quality assessment and improvement practices occurring, such as M&M meetings. It makes sense to us when they're already the infrastructure where complex cases where patient harms occur is being discussed, that we should be able to insert a standardised non-technical skill assessment pro forma or some kind of mechanism to really get on top of this. And finally, there are evidence-based non-technical skill improvement strategies out there. They need refining, but we know certain things do work, such as coaching or practice with debrief or simulation, as was raised before. And putting all of these things together, we do firmly believe that we can reduce preventable patient harm. Thank you very much.
Thanks very much, Jesse. That was enlightening and in some ways a little bit frightening as well. You have a few questions turned up from all of that, which is great. From Daniel Novakovic, he says, when you say change over time for non-technical errors, was there any intervention that was being measured?
No, there wasn't. So over this study period, RACS was hosting 2 courses. There was the TIPS course, the Training in Professional Skills, which does have components of non-technical skills. And for a time, there was the NOTS course, which comes out of Aberdeen in the UK, I believe, which has no longer been continued. Beyond those 2 national level courses, no, there were no formal, widespread non-technical skill improvement activities available.
And on a similar sort of line from Nick Stowe, why would you expect to see a difference over time? Was there an intervention being measured or just expectation that general education may lead to improvement?
Another great question. It was less about expecting it and more to see if it was changing on its own. We know that communication, or the importance of communication, is continuing to be highlighted. There's certainly been a shift in sort of consciousness, if you will, around surgical safety with the introduction of the WHO safety checklist and other such mechanisms that is now focusing our attention towards non-technical aspects of surgical care. So we wanted to see if naturally, through generational change, there was a difference. And no, there was not, meaning that we need to do something, and this will not change on its own.
Okay, so general questions we have here from Stuart Proper, saying that there will always be staff, even team members, who do not want to be there or to be involved. How do you relate to people that do not want to be related to? Maybe Marini.
Thanks, Phil. Thanks, Stuart, for your question. Look, it's always hard, I think, when people don't want to be there, and you can't really make them engage. But you have to make it easier for them, I think, to engage. And, you know, you have to, in your mind, try and figure out they may be busy or burnt out, or, you know, they may be cynical or lacking confidence. So I think your approach to that person probably is important. And, you know, instead of using expressions like, I need you to do something, which is our natural thing, is to direct you and go and do it. It's like, can we agree on the next step for this particular patient? So it shares the task load, and then, you know, asking them things so that you're curious about their opinions in terms of, you know, what do you think is important? I think, what is your biggest concern with this treatment or this patient? Am I missing something? And that way they're more likely to engage, I think, because we're interested in them, and we're helping them be understood in terms of why they're they're disconnecting. And I think one of the other things too is we probably need to not take it so personally. I mean, you know, just because they're not engaging with your ward round, it's not necessarily that they're rejecting you. It's just they may have had some pretty poor experiences in the past. And it's a matter of bringing them along and respecting their autonomy and reinforcing to them that, you know, and telling them that we think your input, or I think your input, is really important to the management of this particular patient. And I think it's being fair and listening to them and asking them their opinions. And, you know, they may not like your approach. Sometimes we're a little harsh, and sometimes we can be a little targeted and we can be a little short. But I think if you're interested in people and you're interested in their opinion, they will see you as fair, and they may engage because they sort of start thinking to themselves, this is a personal issue where I need to engage. And of course, if they're unwell, then that also needs to be appreciated, and there are various avenues by which we can address that as well, or provide support to them either in the hospital or outside the hospital, because there is a raft of things going on in their life that may be affecting their ability to engage when they're on the ward or in a particular clinical setting. So that's how I think we can go about it in terms of bringing people along and empowering them to tell us, or challenging them to tell us, you know, what they think is important and how they can improve the management of a particular clinical scenario.
Thanks, Manny. Give this one to Ben. This is from Sarah Cole. The concern is that consultants, senior clinicians, we're moving further away from direct communication, amplified by AI and budget considerations, pushing patient interactions to allied health. So if we can't talk to patients or their families, what strategies do you recommend, and how to get the registrar, allied health, AI to show us these subtle cues that we normally pick up on?
So when I first read this comment in the chat there, I hoped it wasn't true. But then I reflected on my time on the pain round, which I do once a week or so, and I realised that it is. The patients don't feel that they see the surgical. I'm generalising broadly, but they often don't feel that they see the surgical team, and they don't feel communicated with by the surgical team. And they often feel talked over or talked about. I think this a lot of this comes to what Marini was saying. The health system clearly isn't helping, providing very little time for senior surgeons to be involved directly in patients' care outside of the operating room, and relying in the public system on junior medical staff to do that work, and in the private system, potentially allied health staff to do that work. I don't think there is any replacement for seeing a patient and talking to a patient yourself. I certainly don't believe that AI is the answer. Other than donating quantities of time, I really don't have I really don't have an answer. I mean, one thing that I'd be interested to say is just that there are some studies that demonstrate how you can improve the quality of the time, or the apparent quality of the time that you spend with patients. And one of the things that's very simple to do is just to sit down when you get to the bedside. If you sit down when you get to the bedside, the patient perceives that you spend significantly longer with them and feels that it's a more valued interaction, rather than if you stand at the bedside. But it looks like everyone's keen to have some input on this point.
Interesting for your work, Jesse. It's a question for me, really. A lot of it is, as you say, outside the operating theatre, and yet, as both Ben and Marini said in their talks, we're spending a lot of time now in the preoperative decision-making, particularly for elective cases with MDMs and this sort of thing. It doesn't seem to be making that much difference, does it? That should be sorting out the decision-making, but it's not.
Yeah, it's a great point, and if I had to put that down to why we're not seeing a difference, I would say it's because there's no standardized and there's no validated way to do it. You know, M&Ms are completely different, though widely accepted, they're completely different from department to department in terms of who needs to attend or how many people need to attend, the structure of the meeting, all those sort of things. But fundamentally, there is no, or there has been no non-technical skill specific nomenclature or pro forma put through it. I'm not so arrogant to say that just by introducing it, it'll solve all the problems. But this then feeds into the answer given by Dr. Slater as well. I think we're talking about a generational change here. If we can start introducing it in, if we can make it widespread and we can start talking about the same language, and then though the seniors of the team often don't have time to have those extended conversations with family or family members, the juniors do. And so by giving time to offer generational education to the juniors of the team, and through the other members of the care team, through your M&Ms and your MDTs, using an accepted nomenclature and methodology, I think that's over time where we're going to see a bit of a change.
Great. Marini, you got your hand up, I think.
Yeah, I was just going to share a little bit more on what Ben was alluding to. And see, one of the biggest challenges we have is all the things that senior clinicians used to feel, or they had their spider feelers out, you know, such as the changes in patient behavior, inconsistencies in the history, the anxiety, all those things. They're the things we're not really picking up because we have less and less time. And Sarah's alluding to a lot of this nuanced approach where it's almost a gestalt. You know, you sort of see it and you think, oh, you know, I sense that there's something going wrong with this patient. And perhaps our challenge to the next generation when we do spend more time with them, because we have to use them as a sounder. They're our ultrasound or they're our radar, but we need to sort of move from, you know, information, which is they're really comfortable providing, to maybe signals in terms of what they're worried about. And that takes a certain amount of reflection on their part, a maturity. They have to put themselves out there, but instead of having something like, okay, the patient's stable, it's like, you know, what are you worried about, or what surprised you in this particular interaction with the patient, or what doesn't fit, you know, and it's not that you're giving them a hard time about the information they're providing, but you just need a higher cognitive process to try and deliver you with some signals and to teach them how to do that. And I think that's where a lot of our time may be spent sort of moving forward, teaching them about those signals so we can teach them about sort of red flags on ward rounds or in clinics, or, you know, what actually asking registrars, I think, is quite illuminating in terms of what concerns you about this particular patient, or family signals, you know, what is the family trying to tell you, or human factors, you know, like why are they withdrawing for this particular care? And I think it's that level of reflection and trying to show them the softer signals that we always look for as clinicians. It's not necessarily the harder data points that I think will help that next generation be really good advocates for the patient, but at the same time appreciate and become better clinicians when they're at the level where they're the senior consultant. And I think we need to flip that paradigm, because we're not going to have more time, I think, moving forward. We're probably going to have more patients, and we need to just try and use some of that data that Jessie is starting to deliver to develop these non-technical skills. Because I agree with Jessie. I mean, I'm horrified when I sit there in a nice way and think about how much these issues are contributing to adverse events in the hospital. And then I see institutions withdrawing support from programs that used to try and address some of these particular issues. And that's where I think we're seeing that disconnect between what we need and what we're getting. So I too encourage you, Jessie, to keep delivering on that data.
One more question before we close up, and this is for Jessie from Stuart Proper. Did you recognise any differences in the results between private and public hospitals?
Yeah, another great question. So in the earlier studies, when we were still casting quite a broad net, so where we included all specialties together and then the specialty specific one, yes, we did. Within specialties, we found that there were differences in private versus public. We also found those differences between elective and emergency and various other things. The reason we stopped doing that in the more granular analyses is we realized there are so many other factors when you're looking at a national cohort that this is really most likely to be confounding. And we thought, you know, making a bold statement about public versus private probably wouldn't be that helpful, but was important to highlight just the need to get more granular with our analyses. So the short answer is yes, there are differences. The more diplomatic and I think curious answer is, why are there those differences? In what circumstances are those differences? And do those differences really matter? And so further research needed here.
Good answer. Thank you very much. Well, we'll call that a day. I'd like to thank all the speakers. It really has been a fantastic evening. I've learned quite a bit, which is good. I hope all the audience has as well. And I thank the audience for the questions.